It's launching right now.
And basically, this will be available on our VHPI. Jasper, where will it be available?
It will be available on the Veterans Policy YouTube page.
It's launching right now.
And so I don't know why that's giving me, but and so we will send you a link, and also anybody who registered and who wasn't able to attend. I'm very excited to see so many people that I know, and there's a lot of people like Tom Munneke who have been involved in this for a really long time. Tom is one of the hard hats who developed Vista. I can't see everybody, but there's a whole lot of people who are really super knowledgeable, and I hope will ask questions. We have an hour, but we always say that if folks want to hang around or have more questions or want to continue the discussion, we aren't tied to that hour. People can stay. Essentially, what we're going to be talking about today is this very controversial Cerner Oracle electronic health record that has been rolled out in 6 sites, I believe, and now going to be rolled out in 13 more starting, like, was it yesterday? In, I believe it's Michigan, Ohio, Kentucky, Idaho, Alaska. I might have gotten it wrong. Brian will correct me. And we have some really great experts to talk to you about the myths, really the myths that and the origins of what is many people believe a pretty disastrous action that was taken to replace the most beloved and user-friendly electronic health record in the business with a off-the-shelf product that is a very low performing and has created lots of problems, which folks will go into and describe. I just want to say that in my experience and looking at this issue and following it, I find that folks in the VSO community and on the Hill seem to have several ideas or magical thinking tendencies that we're going to look at today. One is, oh my goodness, it's so complicated, I can't possibly understand it. So I don't know, we should let Cerner Oracle tell us what to do and we'll do it. I don't understand a thing about computers. I don't know, I still believe there's little like fairies going out there and spreading the words that I put in, into my computer when I write, and you can explain it to me and it goes in one ear and out the other. But there's a lot of things that are very complicated that I don't fully understand. Like, I don't know how a catalytic converter works, but I think my car has one. And I've bought a whole bunch of cars in my life. And they've actually all been pretty good choices. So that one is kind of a problem. Some people believe this isn't a high priority. I think you'll learn that it's pretty high priority because lots of patients are involved. One of the really interesting ones is, well, let's just get this over with. Let's just throw more money at it, get it over with. And I don't know, it'll be done. It'll be done. And we'll never have to spend another penny. Wow, that's a pretty good one. The sunk cost fallacy, and most of us who don't know that theory just call it pouring bad money after good, or good money after bad, sorry. And finally, and the idea that Vista, CPRS, the computer, the electronic health record that's being used now is somehow, like old. And it's like some rusting 1930s truck that's rusting in the driveway. And I don't know, nobody's using it. Or, people don't know how to use the mumps language because nobody can master it. Or, there's just all these myths that are governing what is a very serious issue. And we're here to look at those myths. And we have just an amazing panel. And we're going to begin with Orion Donovan Smith, who is the DC correspondent for the Spokesman Review, which is a Spokane paper. And Orion has done, over the past number of years since it was originally rolled out in Spokane, amazing reporting. And he's going to share with us some of what he's learned and maybe highlight some issues of concern. I'm going to give people 10 minutes, and I'm going to be ruthless because we really want to have a time for questions. So Orion, the floor is yours.
All right. Well, thanks, Suzanne. I appreciate you having me here, and thanks everybody for joining the call here. I see some names I know in the guest list, and I will do my best to keep to that 10 minutes. As Suzanne said, I'm the DC correspondent for the Spokesman Review. That's the newspaper in Spokane. For those that don't know, that's a city in eastern Washington, right near the Idaho border. And my job is to cover the federal government's impact on the region we call the Inland Northwest. That's basically, Washington State east of the Cascade Mountains, North Idaho and the Panhandle, a little bit of Western Montana, depending on who you ask, maybe also Eastern Oregon. And that's the region that has been really the testing ground for this EHR system that we're talking about today. So I want to emphasize first that, I'm here as a reporter. I'm happy to relate what I've reported over the past 5 years or so on this issue. I'm not here to say what the VA should do about this. I understand there are some strong opinions. We're going to hear from folks coming after me on that front. I think it's important to hear from that. The reality is I don't know the best answer to this, but I know it's, I can speak to the problem itself. And I know there are a lot of thoughtful people who are working to try to solve it. So first off, I started this job in 2020, and not long after I started, in October of 2020, is when the federal government, the Trump administration at the time, just before Election Day 2020, launched this EHR system at Spokane's VA Medical Center. But I think it's worth backing up a little bit to just give a little bit of context before we go through all this. So starting in 2015, under the Obama administration, the Pentagon signed a contract with a group of companies to buy and implement Cerner's commercial electronic health record system, or EHR system, across the military health system, which is, of course, separate from VA, right? At the time, the military health system was using this sort of cobbled together system of really multiple EHRs that most of its users thought was pretty bad. By contrast, as Suzanne said, a lot of users of the legacy VA system, Vista or CPRS, think it's pretty good. So it's important just start from that point. These two agencies and these two health systems were not beginning with the same set of circumstances. And obviously they serve pretty different patient populations too, and that's important. So Fairchild Air Force Base, just outside Spokane, was chosen as the military's first pilot site for that new system, which launched there in February 2017. That was just after Trump began his first term. In June of that year, Trump's VA secretary announced the government would pay $10 billion to Cerner to replace the existing VA system, Vista or CPRS, with the same Cerner system the military was just beginning to roll out. After a little less than a year of negotiations, and after Trump fired the VA secretary who had said those negotiations actually hadn't resolved his concerns with the system, the acting VA secretary signed that contract with Cerner in May of 2018. And after a little more than 2 years of preparing and meetings to sort of fine-tune the system, ostensibly, the system launched in Spokane in October of 2020. So immediately, the system caused a whole bunch of problems that are, too numerous for me to detail here. But you can obviously read my reporting, read a lot of, other watchdog reports that enumerate those. But briefly, I'd say, users were not prepared adequately for the launch. Training was very poor. A lot of veterans, as you know, rely on VA sending medication by mail, and that didn't go well. A lot of vets either didn't get their meds or got the wrong meds. They were sent to the wrong addresses, things like that. The system's pharmacy module had other problems that caused incorrect dosages, both in the hospital and outside of it, which is obviously a problem. In the case of something like chemotherapy, where an incorrect dose can be deadly, it actually caused the clinicians there to just stop using the system altogether for cancer treatment. You can all imagine how consequential that is. And the system crashed routinely, going down for hours at a time. When it was working, this design of the system and its user interface was just so clunky and poor that it slowed everybody down and made it harder for them to provide care to veterans. And the end result, the net result of all that is a lot of veterans getting effectively pushed out into so-called community care, into the private sector. And as of today, more than 5 years later, a lot of those veterans have not returned to the Spokane VA and its clinics. So I just, at the risk of going on, in too much detail, I'm going to keep this to the next, in the next 5 minutes, just talk a little bit about my reporting. This is basically when I started paying attention to this issue. It came to my attention in early 2021. And, when these problems started to surface, the Government Accountability Office, which is, of course, this independent watchdog within the federal government, called for VA to stop the system's rollout until these problems were fixed. And the new VA secretary at the time, Dennis McDonough, halted the system's rollout in July of that year, 2021. But by November of that year, his department told Congress that the system worked well and was fine to launch just a few months later in Ohio, in Walla Walla, Washington, which is southern, sort of southeastern Washington, and at sites in southwestern Oregon, mostly very rural places, with the exception of Columbus, Ohio. Now, in just that, so this was then December of 2021 is when we published our first big investigation into the system and its problems, showing that it threatened patient safety. But at that point, there was no specific case of patient harm that had come to the public's attention, at any rate. Just after we published that reporting in December 2021, Oracle, of course, big tech giant, announced that it was going to pay about $28 billion to acquire Cerner. And then just months after that, VA went ahead with launching the system in Walla Walla, which is, again, southern Washington state. Pretty rural area there, right on the Oregon border. Now, in March of that year, so this is March 2022 now, as I sort of fast forward ahead, we reported the first incident of patient harm that was tied to the system. A veteran was hospitalized in Spokane with heart failure after a medication error contributed to his condition. In any case, as you guys know, I'm sure it's complicated when you say, a computer system caused a bad outcome with a patient. Healthcare is messy and complicated. But this was an incident where, for the first time, we were able to tie that to flaws in this EHR. Less than a week after that, members of Congress questioned VA leaders about it, pointed to that reporting. And despite that, the VA went ahead and launched the system in Columbus. And then about 6 weeks after that, they launched it in the sites in Oregon. Just after that, I reported, based on a draft report from the VA Office of Inspector General, that in fact, VA leaders knew about scores of cases of patient harm to which this system had contributed. At that point, about 150 cases. That number has since risen to more than 4,400 cases, based on numbers I continue to receive from VA through public records requests. And so essentially that reporting caused, or in part prompted, VA to halt the system's rollout in Seattle and Boise, and some other bigger, more complex hospitals where, problems with the system could have really, inflated effects too, because we're talking about relatively small facilities with relatively small numbers of veterans so far. Even so, we have, as I said, about 4,400 cases of patient harm to which the system has contributed in some way. Those cases, of course, range from what VA calls minor to what they call catastrophic. Most of those cases are minor. And if you look at the reporting I published with the Washington Post last December, we spell out some of those cases in more detail. But suffice to say, minor doesn't necessarily mean it's okay. There's still bad outcomes for patients. And I'll just finish by saying, we're at a point now, as Suzanne said, this so-called reset period has just ended this past Saturday when VA launched the system at 4 big hospitals in Detroit, along with a bunch of clinics attached to them. So this is a big test. And the reality is, I don't know to what extent the system has been fixed. VA leaders will tell you it's a lot better now than it was 3 years ago. Providers I talk to at the affected sites say it's marginally better, but still has a lot of problems. And ultimately, the test is going to be, how does it go at these sites in Michigan, and then subsequent launches just later this year elsewhere. And of course, we'll all be watching that closely. But the reality is, people using the system today still tell me they have concerns with it, and they believe it's flawed in ways that are not easy to correct. And obviously, this has caused years now of work within VA and by what is now Oracle Health, what used to be Cerner, to try to address those. I'll stop there, and I'm happy to answer questions. Suzanne, I think you're muted.
I think we're going to take questions after everybody's spoken. I do just want to ask you one question, Orion. Have they had to spend a lot of money to hire extra staff to make this work?
In Spokane, they have. Short answer is yes. The more complicated answer is that they hired a lot of additional staff in the initial few years after launch. So let's say 2021 through about 2023. Since then, there's been pressure on the local administrator and on the VISN to cut that staffing. Basically, as patience has run out with the effects there. But again, those effects are persistent. The overall decrease in productivity, i.e., they can't see as many patients in the time they have, and it's been pushing more patients out to the private sector.
Thank you. So I'd like to move now to Rachel Madley, who is the executive director of the Center for Health and Democracy, which is a nonprofit that develops and advocates for healthcare reforms that prioritize patients, not profits. Before I got to know Rachel a number of years ago, when she worked for Pramila Jayapal in Washington State, although she was in DC. And Rachel's going to give us a bit of a historical context about, as well as a current context about the tendency to, if the VA or if government wins the competition with the private sector, to punish it by trying to shut it down. And I think that's what we're seeing with the VHA in general. So Rachel, thank you so much.
Thanks for having me, Suzanne. It's great to see everyone. Yes, I'm going to talk about how what we're seeing with Vista and with Oracle really mirrors what we see with a lot of other federal health programs. And I'm going to walk through some examples of those other health programs when we've seen things like this in the past. And then I'm going to get to, what should we be looking for when we compare federal health programs to private sector alternatives? Because I think it's often in an uneven comparison, and I'll get into that in a little bit. So Vista has been, as you all know, it was an incredible development, and it was really well liked by providers and patients, and it is still really well liked by providers and patients who are still using it at their VAs. And as many on the call know, a lot of other countries actually took Vista and used it as the foundation to build their electronic medical records, and those are thriving as well. What we're seeing now with the essentially privatization of the VA electronic health record really parallels what we've seen in the Medicare program and the Medicaid program. And I want to start with the Medicaid program. So recently, we have seen that over 40 states now no longer actually publicly administer their Medicaid programs. There are a lot of different drivers to this, but one is that private industry, specifically private insurance companies, for decades have been spreading the narrative that they are more efficient at health coverage, health care, and that we should be using these more efficient alternatives in our federal health programs. They promise things like cost savings and shorter wait times, streamlined operations. We have now seen that that is not the case when these states have private managed care organizations manage their Medicaid. What we are seeing in those states who have contracted with these organizations, and keep in mind, these organizations, the managed care organizations, are run by United Health Group, Aetna, the very large private health insurers that are involved in other federal health care programs, and in United's case, also involved in the Veterans Community Care Program. What we're seeing is when they start to administer a state's Medicaid program, they impose specific networks of providers that patients can see. And what they often do is make those networks very narrow. And there's been some documented cases from whistleblowers where a network for a child contained almost no pediatricians. And again, that just adds barriers to people being able to get care. We're also seeing that these managed care organizations have much larger administrative overhead costs than traditionally publicly administered programs. So in the case of Medicaid, states are often spending between 15 and 20% on overhead costs going to these managed care organizations. And recent research from Physicians for a National Health Program showed that actually these amount to between 19 and 33 billion dollars in extra costs to states each year because of these private managed care contracts. So here again, the promise of lower costs of better care with private alternatives in Medicaid did not happen. Now there are some states who are turning back away from privatization of Medicaid. For example, in Connecticut, they deprivatized their Medicaid and now they publicly administer the program. And what they've seen not only is millions of dollars in savings, but they also saw an increase in early cancer diagnoses and a decrease in emergency room visits compared to New Jersey, which is a very similar state demographically, but did not deprivatize their Medicaid. So again, the promise of the private sector just does not come true in these federal healthcare programs. I want to shift to the Medicare program because this is even more egregious in terms of the privatization, the promises, and the actual results. So within the Medicare program, there's the traditional Medicare program, which is publicly administered, and then there's Medicare Advantage. This is a version of Medicare where a private insurance company, again, think United or Aetna, manages your Medicare coverage. Again, when Medicare Advantage first started, it promised to save the government money. And that was one of the biggest drivers of passing it through Congress. To date, it has never saved the government money compared to traditional Medicare. And it actually costs 14% more per enrollee. So again, those promises are not coming true. They also put up obstacles and barriers to care. But here is where I really want to highlight, we're also seeing now the privatization of traditional Medicare. So we had Medicare Advantage, which was a big infiltration of private companies into the Medicare program already. Now what we're seeing is these Medicare Advantage insurance companies have now gotten approval to start administering and expanding prior authorization in the traditional Medicare program. And how they're able to do this is they review the claim. The administration specifically chose companies that work in AI prior authorization, and they actually get paid a percentage of the savings that they generate for the Medicare program by denying care. I highlight this because it's really important to see how this privatization spreads if we don't stop it. So we knew this was a problem in the Medicare Advantage program, but it has been decades that this has been happening and nothing has been done to stop this, to decrease the power of the Medicare Advantage companies until very recently. And now they're infiltrating another public health program. The interesting thing here is that traditional Medicare is exceedingly popular and especially handles prior authorization very well. When you compare it to Medicare Advantage, patients and providers overwhelmingly prefer traditional Medicare because it uses prior authorization very sparingly. Medicare Advantage, however, prior authorization is handled horribly. Providers hate it, patients hate it, members of Congress say they hear about it at their town halls all of the time. And so, again, we're seeing a public program that's actually working, that is implementing prior authorization as it should be in traditional Medicare. And in comes the government to insert private companies there to try to save the government money. So these parallels I feel like I need to highlight because we have to look at it as a systemic privatization of our healthcare system to be able to understand the motivations and to be able to push back. And the real motivation behind a lot of this financialization of our federal healthcare programs is that everything in our healthcare system outside of the VA and outside of some parts of Medicare is built around billing and making money from the healthcare system. And I think that's the beauty of Vista, but also why folks at Oracle and Cerner, and even some folks who have been brought in from insurance companies into VA leadership don't understand the strengths of Vista because it was truly built for patient care and for provider ease. And when you look at any other EHR on the market right now, it's built for billing. And if there's any clinicians on here, you know that more than you're so familiar with that because it is such a pain to use it as a clinician because you have to document as many codes as possible to increase the reimbursement. And you have to make sure that you're checking a million different boxes, again, all around the payment, the billing, and the claims, that it falls short in providing for patients and providing for physicians. However, when we're comparing between the two in government leadership, they see the billing aspect and the revenue aspect on the commercial side as benefits. When in reality, what Vista offers is truly a benefit because the patient and the provider should be at the center of healthcare, and it should be as easy as possible for them to use both the healthcare system and the electronic health record. And so, keeping in mind not only, what we're fighting against, but why the system is set up this way is really, really powerful in how we push back against it because we have to understand these arguments that the private sector is making in order to push back against that. And so, and I've been talking to Suzanne about this a lot, but if there were to be an unbiased comparison of Vista and Cerner, we have to make sure that we ground it in what the VA really needs in an electronic medical record. We should not be looking at what Cerner thinks it needs in an electronic medical record or what a private insurer thinks it needs in an electronic medical record, because again, those are going to prioritize the billing and the revenue side, whereas the VA prioritizes patients, clinicians, and also the fourth mission, which the electronic medical record can also help fulfill. Whereas, as we saw during the COVID-19 pandemic, our siloed for-profit electronic medical records cannot help fulfill that fourth mission. So I will pause there and just thank you so much for having me and allowing me to talk about, all of these events of privatization, because it's really important that we fight back on them.
Rachel, thank you. Thank you so much. And I would also add that there are two other missions that I don't think the Cerner, and I know Glenn will talk about this, Oracle product deals with well, which is the teaching mission of the VA. And, I recently talked to a staffer on the Hill who was fairly up on clinical care issues and was surprised to learn that the VA teaches, over 40 different health professionals, and that staffing and outsourcing impact the ability of the VA to get accreditation. So I know, Rachel, you were on the Hill and dealt with people who were sadly not necessarily up on what they should be up on. So we have to talk about that. And I think that's a great way to introduce Glenn, because Glenn Graham, who is a VA neurologist, he worked for the VA for 35 years before he recently retired. He was a founding president of the Association of VA Neurology Services and recently retired executive director of VHA's neurology clinical programs. And he is both, delivered clinical care and dealt with teaching and research. And I just have to say that, Glenn, we would have preferred for a working VA doctor right now, or nurse or psychologist, to be here to tell the folks how good Vista is. But unfortunately, in the VA today, if you are a clinician or anyone working in VA and you tell the public how good the system is, you will probably be fired. So Glenn, who has just retired, cannot be fired. So Glenn, please help us learn more about, the fact that Vista is not this old rusting car sitting in the driveway, but is being used as we speak hundreds of thousands of times for hundreds of thousands or maybe millions of different tasks.
Sure. Well, thanks very much, Suzanne. And again, I know there are other people on this call that have experience, maybe in some ways more extensive than mine. I'm going to share a little bit of my perspective as a research and education oriented clinician who's provided care in the VA for many years, and then as someone who implemented and led national clinical programs that relied extensively on the medical record. As I think Suzanne mentioned in her opening statement, CPRS Vista is still very much of a live product. It's used all the time. We've had approximately 10 VA medical centers switch over to Cerner or Oracle. That means that the rest of them are still on Vista CPRS and are still doing work and doing well. Over the years, certainly the system has evolved. The idea that, well, this is something that's archaic and hasn't been modernized. Yes, the focus in the last few years has been on switching to the new medical record. However, if I think of the first instance of this, it was not even a Windows-based program. So clearly there's been major evolution along the way and major improvement to the system. And the CPRS Vista system is really designed around the VA's clinical mission and the clinical work that VA does. Not focused, as Rachel is mentioning, on billing, but focused on clinical care and other aspects of clinical data collection, informatics, etc. If we think historically as the first comprehensive and broadly implemented electronic medical record before Epic, before Cerner, before all these others, the advent of CPRS Vista, which was sort of a field project in the VA, as I understand it, really was a boon to VA, not only VA clinical care, but also VA research. The fact that a VA and a veteran anywhere in the country had information collected in a common system. This information could be retrieved if appropriate for clinical research, for health services research. I think explains much of the reason why, particularly in health services research, the VA remains, a leader, if not the leader in the U.S. in that type of research nationally. The early adoption of this national medical record framework, I think, clearly underpinned that. And I know this was the envy of people who worked in other healthcare systems, even some of our major academic medical systems, which, even if they were unified internally, if they tried to collect data more broadly, tended to run into obstacles right away. So I think that's an important, since the VA has missions to not only provide clinical care and to be a healthcare system of last resort in case of emergencies, but also to be a leader in education and research. Clearly is held, at least in the research mission. It also is true that since the VA, approximately 70% of physicians get some of their training in the VA, and they may go different places for their medical school training, internship, residency, fellowship. The fact that the VA, once they learn CPRS Vista, they can, if they change institutions, they have the same system, clearly helps in terms of bringing trainees into the system and allowing them to clinically integrate quickly. I mentioned that this is not a static system, and as medical care has evolved, as care in the VA has evolved, CPRS Vista has proven to be fairly flexible with continued investment. For example, having instituted a number of national programs, we're wanting to have consistent data elements collected in a consistent format. We were able to generate templates that could then be rolled out nationally through the CACs with appropriate approval, and then exist identically across the enterprise or across as many facilities as have need for that template. VA has long been able, through various means, and they've gotten better over time, to allow a clinician who might work in one VA to access aspects of the medical record, reports, studies, clinical notes from other VAs. A challenge has been that each VA system, each station is its own instance of CPRS, meaning there's a different code that you use to access your home VA's record versus others, which means that if you wanted to generate notes or write orders on another system, you had to be separately enrolled in that system, appropriate because you want to make sure people have privileges, but it also can pose barriers when you get a plethora of usernames and passwords. One thing, as we rolled out our telestroke program, which provides now emergency care in 81 VA medical centers around the country. But early on, we realized that this was unwieldy, and we found a system in VVA that automates this process of keeping your username and password, a single one, consistent across the enterprise. So this has now been incorporated into a tool called WebVRAM that's available for multiple programs. Just another example of how CPRS Vista is more flexible than some people give it credit for being. Similarly with scheduling, with the need to schedule a patient here and a clinician there in, let's say, a telehealth encounter, there were changes in scheduling package that allow that to be done also. I think one thing that we have to consider is that an evolution of a medical, change is hard and change is inevitable, but an evolution of a medical record is likely, if it's done with any sort of intelligence, to be far less disruptive than an abrupt change. This is, I think, shown when we ask what clinicians would prefer. I can't think of a single clinician that's ever come to me saying, I'm enthusiastic and eager to make the change to Epic. I can also say that enormous numbers of person years have been spent working with Epic VA clinicians and of various sorts, working on committees, working on task forces to try to make Epic, Cerner rather, usable. For example, in neurology, they initially had basically two sorts of notes: an inpatient consult and a clinic visit. What is that? That doesn't account for so many things that we do, diagnostic studies, emergency room visits, et cetera, et cetera. And this was really what they came out with. And then neurology especially was fairly low in the list of places that got to give their input. So someone was kind of rushed through. This is the sort of problem that we would have had if we had done what the military did, from my understanding, is just basically take something off the shelf. Was not well attuned to what the VA did, still isn't. And remember that the VA medical system is far larger and far more complex than the Department of Defense. So those are all, I think, issues. The other nice thing about developing your own medical record system is, rather than outsourcing it and paying someone to make a profit to do it, and then anytime you want a scope of work change, that typically means more money, or at least high ongoing fees. If this had been done internally, I think the opportunity really to just give us part of the billions of dollars, half of the billions of dollars that have been spent on the outside, I think folks could have done a little better job. So that's a little bit of another issue I should say is that initially the plans for training people on CPR on Cerner were very fragmentary and very poor. Let me tell you about how this caused us problems. We're running a national system with doctors all over the country, connecting to emergency rooms and inpatient areas all over the country. When one site converted to Cerner, we had to retrain our entire group of doctors. And there was no training that was focused on what we needed, namely as a consultant, as opposed to a doctor working in the medical center for all of his or her efforts. Orion spoke about the situation in Spokane. We were delayed by many, many months, probably between 1 and 2 years of implementing telestroke there, simply because of this barrier. They couldn't get our doctors efficiently trained to go on onto their first Cerner site. So just another issue. I think that gives a little bit of my perspective. I'm certainly happy to take questions. I can't tell you how many, since the program wasn't there, I can't tell you how many people might have been helped by our National Telestroke program had it been implemented in Spokane sooner, but the possibility if they're missing a few cases certainly is there. I just can't give you a number on that. I think that's about it. Thank you.
Thank you so much, Ken. Thank you. We're going to be, I hope we can extend over the hour for questions because people are have so much great information to share. So I'm assuming that the speakers can stay on and at any rate. So Ed, I am going to just read a couple things about you. And Ed has been with VA in various positions like Assistant Secretary for Information Technology, for the Deputy Assistant Secretary for Information Technology, et cetera, Deputy Chief Information Officer. I want Ed to talk rather than me to dazzle you with as the other speakers with their credentials. But Ed has really had a front row seat at a lot of these decisions, both in the VA and in the DoD for 26, really from beginning 2000 to now. And he's going to talk to you about these pernicious myths that are being spread and what we can do. Ed.
Thank you, Suzanne. Let me start by saying, a generic view of what the current electronic health record modernization program is. It's a political solution. It's a misguided political solution to a DoD contracting problem. The solution was created by uninformed, misinformed, and in some cases malintended individuals. And they were more interested in building out the DoD problem, Project Genesis. They were more interested in solving that problem by using VA resources, or actually to expand it to a larger perspective, to aid in the privatization of the VA by dismantling piece by piece and disassembling an integrated electronic health record, which is VISTA. It was premised on two lies. One is that VISTA is old, archaic, out of touch, cannot be improved upon, and that somehow or another DoD and VA, the only way they would ever be able to share common data would be if they were on the same platform. And you have to go back a little bit into history in that DoD has a 20-year history of failure in trying to create an electronic health record. And they decided they had to go with a COTS product. And they selected Cerner as the low bid. None of this, says you're going to end up with a good product to begin with. What you can say about Project Genesis is that it's better than what they had, and that's what we call damning with faint praise. However, there was never a requirement at the VA for a new system. In fact, in 2017, they had just finished a project on the future of VISTA and how it would be modernized, and they were moving in that direction. The other myth is that VA couldn't keep up. It's on old technology. That has been totally found to be untrue. Matter of fact, over the last 5 years, VA now exists on there's a single instance of VISTA now. It exists in the AWS cloud. It costs about $10 million a year to run it. It is now the most secure system. Bear in mind, they are using the electronic health record, does not have an authority to operate. It is not a secure system. VISTA is. It has, because it's in the AWS cloud, it has backup capability, it has security. The CPRS, the user interface, has been ported to the same technology that Netflix uses, and it has been dramatically improved. To this moment, if you were to put any kind of a rational comparison between Vista and any of the other COTS products, Vista would come out ahead for sure. It is a more modern, more extensible, more secure program than any of the other COTS products. And I think a couple of things that get dramatically overlooked is that Vista was created by the clinicians who use it. They have repeatedly stated that Vista helps them be better physicians, helps them be better clinicians. It does medicine the way they were trained how to do medicine. It is not insurance-based medicine. It's medicine that's in the best interest of the patient. Whereas Cerner, its only real claim to fame is in revenue cycle management, meaning it captures costs better and it's better insurance-based medicine. And so what you're doing and what is being done here is they are taking all of the institutional knowledge, all of the lessons learned over 30 plus years, and they're throwing it out. And instead, they are putting in a COTS product, which was based essentially on revenue collection, and all of the medical parts to Cerner were actually acquired piecemeal by buying other companies and cobbled together, and almost as an afterthought. The only one time Cerner actually tends to win new product is when a hospital is struggling with its revenue cycle management. It does that pretty good. It's built essentially on top of an accounting package. So my criticisms are that we've spent $20 billion on a COTS product that dramatically reduces productivity, that has caused all sorts of errors, including veteran deaths. We're spending $20 billion on the way to somehow $50 billion. We're not improving care. We're reducing productivity. We're crippling the morale of the clinicians at the VA. And at the same time, we have a best of breed series of applications that are being used now successfully at 160 veteran facilities, VA facilities. And we're abandoning this because of political decisions that were made 10 years ago. People ask why. Too big to fail, perhaps. Maybe too many reputations have been based on a lot of bad decisions. Or maybe it's even more draconian than that. Maybe it's the fact that, as we've seen at these 6 facilities, it actually causes veterans to be forced out onto the community care. It actually depresses the morale of the clinicians and causes them to want to leave. You can apply your own judgment as to why that is. But if there was any fair comparison between the care delivered and the cost of that care and the satisfaction with that care at Vista compared to any of these, but certainly Cerner, that would fail immediately. So this is such a bad idea. It has been propagated for so long. Some of the reputations have been predicated on it. And the issue really is there anything that can be done to make people stop for a second and say, why are we spending perhaps $50 billion to replace a system that's working very well and is on a path to being improved consistently? Why are we doing this? And I'll leave it with the final point is what VA is really giving up is control over their destiny. Right now, as Glenn has pointed out and others, VA controls Vista. It can make whatever changes it needs to make. It can adapt it. By moving over to Cerna, you become just another customer. You have no control. You can't make any changes to the software. You have to make requests and then pay for them and get put in a queue for any adjustments or changes. You're living on an unsecured platform that isn't delivering to the veteran. And so I just think it's a matter of, somehow, some way we must get our leadership in this country to realize that a terrible disservice is being done, not just to the veteran, not just to the clinicians, but to the country in general.
Thank you so much, Ed. That was great. Um, so we have time for questions. We have as long as we need. I'm not quite sure, Jasper, how do we figure this out? I mean, there are some folks who I know Hugh Foy, who is an advisory board member for VHPI, has had some pretty astonishing experience with Cerner. And maybe, Hugh, do you want to make a comment?
Well, I'd say I'd be happy to for the effort, but it wasn't a happy experience. I'm a retired surgeon and intensivist at the University of Washington, based out of Harborview. In about 1988, a guy from Chicago came to Harborview and they developed CIS, which was the first really decent ICU spreadsheet. And we had our own in-house EMR with CIS and also with Mindscape, where they used HTML for just documents. We then were looking for a comprehensive healthcare record platform, and what CIS was got bought several times in that early 90s, late 80s from Motorola, and then finally ended up in a company called Eclipsys, which had a pretty decent comprehensive inpatient system. And we then wanted to expand, and so Eclipsys had a proposal that wasn't yet developed for a comprehensive, which included a physician order entry and ability to view x-rays, et cetera. And its main competitor at the time was Cerner. So because of the corporate turnover of Eclipsys, there was a little blood in the water with service, et cetera, after we lost control of our in-house record. So the Cerner people came out and gave us a pitch. This was about, I don't know, early 90s. The exact dates is about 90, 91. It was a disaster. They were ill-informed, uninformed, and every time we would ask them in the demo to show us something like physician order entry or one click to see an x-ray, it became, well, we didn't bring that module. And I personally went to St. Paul's in Vancouver, BC to see what they had from Cerner. And it didn't exist. And it was always, well, we didn't buy that module because it was too expensive. I went to UIC Chicago because a good friend of mine was chair of general surgery there, and I went to see their deal. Same story. Well, so what Cerner did, and this is a indirect quote of our former medical director at Harborview, he said, they pitched us that we were buying for X million a Lexus to drive off the lot.
Yeah, buddy.
It turned out to be boxes of car parts, used Toyota car parts. And every time we would have a problem, they had a strategy. Well, we're stupid. We don't know what we're doing. And they were always dancing around the issues. Now, this is some sensitive information I'll share with you. First of all, this is a fact. We paid X millions for this system for 2 hospitals, Harborview and UW Medical Center, which aren't that big of hospitals when you look at it nationally. I mean, 400, 350 patients in the other. We paid X. It took 10X million and 10 years to implement what they said we were going to drive off the lot. And their service was abysmal. The transition was a mess, and it never saw the light of day. And I was on the advisory board for the EHR or EMR at the time. And I told them, I said, I'd cut our losses right now and I'd sue Cerner and get out while the getting's good. And they responded by relieving me of my administrative duties on that committee. But I was when Cerner got the deal for the military, I was told in confidence by a colleague who's now passed away that it was a pretty shady inside deal. And that's how they got the contract. I never got the specifics on it, and the guy, like I say, has since passed. But I wouldn't trust Cerner farther than I could throw him with one arm. They should have gone to prison what they did. We were two hospitals, and they took us 10 years and 10x over what they projected and sold us etherware. They should have gone to prison for that. And instead, they get a multi-billion-dollar contract with the United States government. So, we're all kind of pulling our hair about corruption in the current administration. It goes a long way back. And I've just pulled up my records today. My trip to Chicago and Vancouver was in 1991.
Thank you.
So the whole deal stinks. Like I say, they're not to be trusted. And I just saw, Orion, I just pulled up your article about this guy who just within the last month got accused of graft and corruption with implementation of this stuff. I won't mention names, but it's in your news feed. And the word on the street has long been, this was an inside deal, it's crooked, and these guys are incompetent. And history has borne that out.
Thank you, Hugh. Ali Parand?
Yeah, just a quick follow-up to what Dr. Foy said. I've spoken to multiple physician executives in VACO that are currently in VACO and that have been in VACO in the past, and a lot of frontline, and I've also spoken with a lot of frontline physicians that have been at rollout sites, and as physicians we're always asking why, like why are we doing this, and thinking through what are the ramifications, the downstream consequences, risk versus benefits. And after extensive conversations with multiple VACO executives that are involved in the AHRM rollout, ultimately, question after question, they don't have a rational answer. And the end answer always is because the president wants it. And that's what's demoralizing frontline clinicians, because that's not an acceptable answer. That's not when we're trained to discuss, say, patient care, what's best for the patient. Say we're in a tumor board setting or something like that. We have multiple different specialists around trying to figure out what's best for the patient. In this case, the patient's VHA, Veterans Health Administration. Nobody would dare, come up with a top-down answer like that. And that's demoralizing to us, because it goes against our oath, our conscience, our integrity, against everything that, we base our careers on and our integrity on.
Thank you so much, Ali. Are there other questions or, I think it's pretty interesting for, if anybody, David Shulkin, who was Trump's VA secretary for a nanosecond, sort of initiated this deal. And it's quite interesting. I reviewed his book when it first came out, and I just reread it. And people should go back to that book and see what a complete muddle it was as how he described it. Because at one point, Trump said to him, why can't we get something that's even cheaper than Cerner? It's fascinating. And, Dave Chilkin has been saying things like, and I think Tom, who has his hand raised, can answer this, but that, the technology is archaic. Nobody knows the mumps language, which I've learned is completely untrue. And I think Tom Munneke can disabuse us of that, but it's certainly an interesting book to look at, given Shulkin's attempts to justify his decisions today. Tom, would you like to say something? And by the way, you're muted. Okay, but now you aren't.
Yes, I have many, many things to say, Suzanne, and thank you for inviting me. It's hard to know where to begin, but I was one of the original hard hats that developed DHCP, we called it at the time. I was recruited out of the Mumps Users Group. I was working with a woman named Judith Faulkner, who was taking the same ideas that I was taking into the VA, into her proprietary system, which became Epic Systems. I kind of lost contact with her. We were public domain and open and more than happy to incorporate anybody's ideas, including CompuDocs, we call them, like Glenn. I've never met you, but you're exactly what we were hoping to see evolve over time. So that was where this sense of Vista as a community of people, I think probably over 1,000 people developed Vista. They all had this sense of paternal, success has many fathers, failure is an orphan. I mean, sorry for the racist or sexist thing there, but a whole lot of people feel as having contributed to Vista. And they were very talented. They were directly connected with the patients. They had their sense of health that's their career and their passion. And to be able to pull those together essentially for free. You recall we were just maybe a dozen people. We couldn't possibly have designed all these things. So we gave tools out to special interest user groups who then developed on their own. So we were building this enabling technology that we saw as Vista. So it is a community as much as a set of code. But I don't know, anyway, it's wonderful to see all this happening. I see these original concepts popping up in people's comments today. I might also point out that I've been through this conversation probably 40 years now. About every 3 years it pops up. Ed Meager, you and I were in the Veterans Affairs Committee, I think about 15 years ago. If you look at my picture here, you were sitting next to me when I took that screenshot from C-SPAN. But that's probably my last formal engagement with the healthcare industry. Everything about Cerner is right. I have many, many stories to tell. I went from the VA to a company called SAIC to do the port of Vista into DoD. I had already done it at Loma Linda as a VA employee. I ported the VA software to March Air Force Base. It was running in the hospital there. A programmer and I did it all in a couple of weeks to get the basic thing started. It was not a big deal. The DoD turned it into a big deal. But anyway, the bottom line is also, do we really want a new EHR as our goal? We're talking about something that's 30 years old of healthcare back in the days of, before there was an iPhone. I mean, that's how far it was. So looking forward, what's going on? Well, you can't talk about anything without AI popping into it. And you can't talk about AI without saying it's going to reduce or eliminate programming. And I found that true. So you can use AI to do everything. It doesn't matter what language you're working in. And then the question is, what do we really want to accomplish with computers and communications in healthcare? Traditionally, we want to be able to build them more efficiently. And the first use of AI in commercial care was called billing optimization. And how can you charge more for this given set of symptoms? And Brigham and Women's Hospital installed that and said they saved 30%. They increased their profits basically by billing 30% more for the same service. And that was the benefit of AI. So how do you get AI to actually talk about the reasoning that doctor goes through? And if you look at AI today, they're all about reasoning. Teslas are learning how to reason and they're driving. We put out this system with tens of millions of records, thousands or 100,000s of providers. huge database, maybe 100,000 data elements, but we never captured the reasoning of what happened when you did this and you found that and it worked again. There's no feedback loop. So everybody was starting from scratch and studying their, medical school knowledge from 17 years earlier. So this sense of learning from your own reasoning in real time with the patient and learning about things just beyond the clinical ICD-10 codes or whatever we're at now. But all of this reasoning could have been a feedback loop, and we would have gotten so much smarter at the clinical level. And this is such an incredible potential that AI can give us that somebody like the VA should be investing in and saying, well, let's just rethink all this. The state we're in right now, I call it the Humpty Dumpty syndrome. We've broken into so many pieces, 1.6 million terms in the Unified Medical Language Thesaurus. So there's 1.6 million terms for how to be sick, basically. And we're trying to figure out how to integrate these through all these pieces here. Anyway, that's basically what I've been working. I've kind of gotten re-energized my healthcare, but I'm basically redesigning what I would have done had I known about AI 50 years ago. But it's just a whole different view of health and vitality and agency and connecting that with the clinical information. But Glenn was talking about having the agency to do his own medical knowledge, and that was what Vista provided him, that the space and the organization and the ability to form a community. So I probably overstepped.
Thank you so much. That's really raises so many questions. I mean, we need really, that was fabulous. We have to have a way longer discussion about what is the purpose of this exercise? What are we spending the money on? Even if we could get the money, even if we could get Congress to give us the money, what is it for? And it sounds like it shouldn't be for a system that doesn't work, that demoralizes clinicians, that threatens patients, and that sends more patients to a private sector that, as we at VHPI have already shown, can't handle them. I'm not seeing, are there other people who?
Suzanne, can I
think Ryan was
jump
going
in for a moment? Yeah,
Yes,
thank you. And I'm sorry to interrupt. I need to go here in a few minutes. I just want to say thank you guys for including me here. I will just say, as somebody who's been involved in a lot of very long conversations on this, they get very in the weeds. I think it's one question I would just have for you guys, and for those of you who stick around and discuss this more, is what is? I see some comments along these lines in the comments here. So what are you going to do about it if you're concerned about this? One thing that Tom mentions the sort of the history of the hard hats developing Vista in the first place way back, and the fact that AI just in the last few years has really created this opportunity to do programming with far fewer resources in terms of at least humans, highly paid humans doing this stuff. And one of the arguments against sticking with Vista is the idea that, well, nobody can learn this antiquated programming language, and even if they could, VA, the public sector is not going to compete with the private sector where people are getting paid, massive salaries to do this kind of work. I am not by any means an expert in that area, but I'd be curious to hear, from other folks, what if you think this recent kind of advent of generative AI opens up new opportunities for, let's say, the new hard hats to come along and create something that could compete with a private system. Because the reality is, and I'll just say as somebody who thinks about messaging, how to communicate clearly with a general audience, this stuff is really, really complicated and hard to deliver a clear message on. And if you guys don't think the Oracle Health system is the good option for veterans and for the VA, you're up against a pretty big and well-funded lobbying machine, and you would need to find a way to probably create some kind of proof of concept, but also deliver a message clearly that, hey, we could save all kinds of money, taxpayers, we could deliver something better. I don't know if that's true, frankly, but I'd be very interested as a reporter to hear more about it. So I'll just leave it there.
I don't know if anybody wants to answer that. I mean, we're sort of running out of time, and I feel like it would be actually great to have a follow-up on this meeting where we addressed just those issues. I think we could make a commitment at VHPI to do that. I need to talk to, I need to figure out who's going to be on that, because this has been a pretty, you know, it's not exactly backward looking, but I mean, I think we need to move forward with where we want to go. And I know that I've talked to some folks on the Hill, and people have said, well, we really need some kind of red team study or some kind of study, you know, which potentially we could get after the next election. Maybe we'll have an Orban moment here. And, you know, but I think that the issue really is, what do we want? What do we want? What are the requirements? So, Matt Stevenson, I'm going to call on you.
Yeah, thanks, Suzanne. It's nice to see some familiar faces on there. I'm also a current VA primary care doctor, clinician educator, population health researcher. I use Vista every day. I used it to run our COVID clinics during the pandemic. Use it to do basically like mass colon cancer screening for tens of thousands of veterans per month via mailed fit tests that sort of Vista coders have that have enabled to get sort of bulk mailed once per month. So in other words, I've seen the way that this old technology can be used to do some pretty innovative stuff. I've also seen just incredibly smart, dedicated, hardworking VA clinicians inspire me continuously over really 13 years of working at VAs. And this feels like maybe in a year when we've seen some pretty devastating hits to our morale and our workforce. This to me seems like the biggest threat on the horizon right now. And I'm hearing from clinicians in Ann Arbor right now who are saying, this is, and in the first day of a EHR rollout, some of this is to be expected, but I'm hearing people say this is an absolute disaster. And I hear from folks in Spokane who are saying it continues to be as bad today as it was years ago. And when you think of, what is the reason for this? None of the justifications, that CPRS couldn't exchange records with DoD health systems, or that it couldn't be modernized. None of them hold up. Or that it would cost $19 billion to modernize Vista. I mean, come on, that is a Vista-based electronic health record was installed across the entire nation of Jordan for $250 million. So there's some other explanation, right? And it is so deeply worrisome that it is almost hard to say out loud. What I'll say is, Cerner's business model is medical billing, right? It's taking the calling of medicine and healthcare and turning it into, what American healthcare is, right? It's a business where we do our best to meet the patient's needs. Oracle's business model is not that. It is owning the data on hundreds of millions, billions of people around the world. There is, evidence to suggest that Oracle is going to divest itself from Cerner. It's certainly laying off thousands and thousands of people at the Cerner headquarters. And I think the question is if they walk away from this product, what are they walking away with? I think the answer is a lot of people's data. And so I agree. And I mean, for me, like, I just want a health record that enables me to take good care of my patients and, trust that their data is going to be secure and, not cost the VA, the amount of money that, money that could be used to hire social workers and psychologists and, fund veterans benefits for, for decades. I mean, so I saw posts in the chat about, what are calls to action and what can we do. VA plans to install this thing at 13 facilities in the coming year. I think, we cannot wait for the new Congress to, do another comparative cost assessment. I don't think. I mean, I think if it rolls out at those 13, it's going to be, I don't know, but I I don't have the answers, but I just want to share this global perspective that's both sort of big picture, but also from someone working on the front line, seeing patients every day, and being deeply concerned about that really the most important tool that my colleagues and I all use to care for patients is being, imagine it, it's a surgeon's scalpel being replaced with a butter knife, because seemingly, the someone who has never done surgery thinks that the butter knife is the necessary product. Right? So I'll
Thank you.
leave that there. Yeah.
Ed, do you want to say anything or?
Well, again,
What
I don't want to get too far afield from, what the purpose here is, and I think Orion's comments very germane in terms of, what what will change, what will fight against this multi-billion-dollar corporation, and I agree completely with Matt that the real gold is in the data. And I think to Tom's point, we don't know exactly how AI is going to be implemented. We just know it's going to change everything. And the code is the least important of any of it. What is important is the business process that has been worked up, best practice that exists in the code. That needs to be salvaged. The data is clearly the most important thing, and then how we apply the AI capability and hand it over to the clinicians to become better at what they do is the most critical thing. We are battling a political decision, and again, as a personal opinion, this has become. It didn't start out this way, but this has become a way to accelerate the privatization of the VA. The VA is the only integrated, large-scale integrated healthcare system in the country, and it works pretty well. Not that it couldn't be improved, but it works pretty well. And they don't want. There are people who don't want that to be the case. And so the privatization of the VA is going on, and I think what we need to do is get down to understanding the impacts and then speaking out at every venue, every avenue, telling your Congress people that this is of concern to you. Of the many things that concern all of us, this is of concern to you because it really does impact what we do in the future with healthcare across the board, not just for veterans.
Yeah, and I'd like to end with basically just saying that, whoops. Is it Allie? Allie, did you have something to say? I mean, is that Allie? Allie, did you have something to say?
Oh yeah, if we have time, I just wanted to. I don't think anybody addressed Orion's comments. Yeah.
And go ahead, Allie, and then I think this will be the last question.
Okay. Yeah. No. I think he's off, but just to address what what Orion had put out there. Um, in a follow up of what I was talking about before, and I don't think I apologize. I didn't introduce myself. Who I am? I'm a full time primary care doctor. I've been a fully paneled primary care doctor at the VA for over 15 years, and 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 I've been in contact with others around the country um, that have been a part of the different rollout sites, and it's especially stressful for those covering full primary care panels in the most complex patient population of any other healthcare system in this country. And any little inefficiency just magnifies incredibly and it burns you out. And so, but with respect to Orion's question, can Vista be modernized? Does new AI coding tools help with that modernizability? And I mean, I've spoken with brilliant bioinformaticists, prior FACO IT administrators. The answer is yes, and yes, and also that it can be done even cheaper now because of these AI coding tools. And so, in when I spoke about earlier in our session, in my conversations with multiple VA physician administrators that are involved in the HRM, both currently and former, my questioning has been about this. Why don't we just modernize Vista? And the answers that they give don't hold water. And when I point that out, they ultimately acknowledge that, yeah, we can modernize it. Some of them will just say up front that we can. There's people that have been in this business that have been in VACO for decades that say, yes, we can. And so the answer is just clearly yes, it can be done. And it would be much better for veteran care, for our veterans, for it to be done. Bottom line, it would be much better for taxpayers for it to be done. Bottom line, I mean, I've had this conversation with multiple people over the years. It's an unequivocal answer. It's very clear. And to quote somebody else that's on this chat, if the Oracle Cerner rollout were not a private company, but the federal government, it would be Exhibit A of government bureaucratic ineptitude, and it would have been canned many years ago. And so, but the answer to Orion's question is yes. Even you could make that debate 10 years ago that it was still the better option, but now it's abundantly clear with new AI coding tools. The question, the answer to Orion's question could not be more clear from both a fiscal perspective and for the future of our veterans and veteran care.
So thank you so much, Ali, and thank you so much, everybody. I think what we really need to do, and I just want to announce that Ed Marr has written an amazing report that VHPI will be publishing in the next couple of weeks, which helps. It's pretty academic and a little bit weedy, but it gives us a lot of, even though I've edited him, thank you, Ed, for taking my edits, but it gives it helped me understand better this whole thing. But I think really what we have to do, and we'd be happy to think about having another meeting on this, and when we have to take this issue and make it comprehensible and credible to veterans, to Congress people, and to BSOs. We've got to get the BSOs off their asses on a lot of things. We've got to make this an election issue. We've got to insist on oversight. We've got to insist on analysis, and we've got to have a clear path forward, because the path that was supposed to be taking us forward is actually taking us backward. I mean, if you have clinicians relying on written, records, you're not going forward. So I think that we have to be animated in our activity and advocacy by the fact that this can be solved, but this is not the way to solve it. And we can help make VA better, and make the health record better. And it is not too late. It is not too late, and we cannot throw bad money after good. I mean, the fact that, even if the estimate for fixing Vista was $19 billion, which it isn't. And they said that was too much. Then how come we can spend 50 or 100 billion, to fix something that is unfixable? So clearly you have the money. This is the beginning of our journey. We need fact sheets. We need credible messaging. We need to all work together. And I'm so glad that we've all come together with such an astonishing panel. And I'd like to bring us together maybe again, looking more forward. And we will be in touch. And thank you for coming. And thank you for staying extra long. We really needed to give the speakers, the time to make their argument, because this is really, way too important and too complicated to get into 5 minutes each. So I want to thank everybody. I want to thank VHPI and my colleagues who work with us. We are dedicated to getting these messages out to fight privatization. I'm going to give us a plug. We need donations. We need to continue with our work. And we're really the only think tank about veterans' healthcare issues. And really, I think one of the biggest forces in fighting against privatization, which we've been doing for a long time, too long. And we need to protect public workers, we need to protect public services, and we need to protect our democracy, and this is one way to do it. So thank you. I'm just so moved by this. It's really been an honor to be here. Thank you.